get started? So welcome back from lunch. This is great. We have the pleasure of our next topic, which is Watch It Parasite, and Dr. Atani, but the speaker is going to be Dr. Jaeger. So please.
Good afternoon. It is my pleasure to present our project here on fighting malaria with image analysis and machine learning, or Watch It Parasite as it is listed in the program. This is a relatively new project. We just started last year, and we got the idea when we looked over the shoulders of researchers at NIAID. And there we saw what they do manually and what we can do to help them by automating their process. So malaria is a mosquito-borne disease. You see here a mosquito feeding on the blood of a human. And during this process, there are actually parasites introduced into the bloodstream, and they affect the red blood cells, and that can lead to severe complications up to coma and death. We have about 200 million cases of malaria each year, which is a very high number, and a large number of casualties. The 438,000 is reported by the World Health Organization, but probably the number is even larger than that, and most of them are children. So if you do the math, there's a child dying of malaria almost every minute. And you see here some people demonstrating here for help for malaria. So 1,000 kids a day. Again, if you do the math, that is almost one dead child per minute. And that's quite a lot. And it's really a rapidly progressing disease. So once a child has malaria, you better diagnose malaria straight away. Malaria is a curable disease, so there are drugs for treating malaria. In fact, just during the last round of Nobel Prizes, the person that has found a major drug in the 60s or 70s got the Nobel Prize in medicine and physiology. And this drug, to this day, is the main defense against malaria. Interesting from Chinese herbal medicine. So by studying the ancient literature, they found this drug. So it's curable disease, but it needs to be detected. So there are 4 ways to fight the disease, basically. One is a rapid diagnostic, which we are here trying to support. The other one is fighting the parasites, the mosquitoes directly, using agents or using bed nets as a passive protection. This is also effective. The other one is better treatment, having more thorough treatment. And the last one is vaccines. There's currently no effective vaccines against malaria. There are many efforts being done, but they have only been partly successful. There may soon be one, but this is an actively investigated field here at NIAID. This has not gone unnoticed, the death toll we have here due to malaria. So the Gates Foundation is heavily supporting research for malaria, and they plan to eradicate malaria, so they're very ambitious here. And they have just unveiled a plan here with the British Exchequer here, George Osborne, and they spend money to fight malaria. So it's a big goal of Gates. As I said, malaria infects the red blood cells. So malaria is typically diagnosed by microscopy. There are rapid diagnostic tests, but they have disadvantages. So they cannot replace, at this point, microscopy. If you're interested, I can tell you at the end of the talk more about rapid diagnostic tests and microscopy, but they are more complementary. They are not replacing each other. So what is typically done here is a blood smear is produced by taking a drop of blood here, then spreading it across a slide, and this slide looks then like this here, and this slide is stained so that the parasites appear in a specific color and are easily distinguishable or noticeable under a microscope. So here you see what is visible under the microscope. You see these are red blood cells, and these are the parasites. These stained blobs here. If you look carefully, you see that they usually have horseshoe type because there's some cytoplasm visible under the microscope, which makes them easier to detect. So the back slide here is from the literature, actually from CDC. The front literature slide here is from our collaborator that we are collaborating with in Bangladesh. So it's actually a slide that we are processing. The different color is just because different staining, but the principle is the same. You see here parasites, and very often, for instance, here you see a horseshoe type. So these are the slides that you look under the microscope. This is what a typical workplace looks like. This is taken in Bangladesh, where we are collecting data for our system. So see, that's the main working tool. That's the microscope. And they look the blood slides. Here you see blood slides, many of them. Usually if a patient has malaria, every 6 hours they take a blood slide and inspect it under the microscope. And this is what it looks like here, for instance, a slide under the microscope. That's what they see. And what they do then is they start counting. They start counting the infected parasites and compute the ratio of how many are infected versus how many are not infected. Usually they use some helps, mechanical helps more or less. A grid, for instance, here, so that they don't count any cells twice. Or here a manual telecounter, so that they press the button while looking through the microscope, so that they don't get confused while counting. They usually count up to 1,000 cells and then compute how many of these 1,000 red blood cells are actually infected, which gives them the infection ratio. And that infection ratio is usually used for either, of course, diagnosing malaria and also for measuring drug effectiveness or measuring drug resistance and disease severity. All manual process. Of course, this is an error-prone process. It depends very much on the fatigue of the person, on the experience of the person, and its motivation of the person counting the cells under the microscope. So, of course, mistakes creep in, and the two typical mistakes are false negatives. In a false negative, the person actually has malaria, but it is not recognized, not diagnosed as malaria. So this involves cost. Of course, the most severe cost here is the person is dying, and actually, in fact, 1 in 300 patients are actually dying from a false negative. Then another cost is unnecessary use of antibiotics, because if it's considered a flu and not malaria, you're giving the wrong drug, and that costs and has no effect. And of course, lost days of work, that has a direct economic impact. So even if persons are not dying, that has an economic impact, and you can count that in money. So there's a lot at stake here too. Then false positives is the unnecessary use of anti-malaria drugs. If you give a person drugs and the person doesn't have malaria, he may suffer from the side effects, which can also cause severe complications. So this is all costs that we want to avoid, and automation can help here, we think. So our idea is to use image processing and machine learning to do the counts automatically. This is where our expertise is. We are image processing guys, and with a lot of background in machine learning, so we want to automate that. Here are some of our background. So OpenEye is a big system here that can retrieve images from PubMed Central, images, photos, and uses image analysis to do so. And it's used by more than 9,000 visitors per day. So that's already quite a success here with our image analysis. Another project we have is the automated screening of chest X-rays for abnormal and diseases, in particular TB. In fact, we have currently deployed a system in Kenya where we run field trials and where we analyze the chest X-ray with image analysis and try to detect abnormality automatically. And we have presented that to the board last year in May. Another project we have is the digitized histology. to detect cervical cancer. Another project that was mentioned here by Betsy this morning is the face matching and the lost person finder, where we were able to to save a life here during the Pakistan earthquake in December 2015. And this is largely based on face recognition. So, if you will, a kind of non-medical application, not cell-based, but still image analysis, what we have in a working system. And also, we have this implemented on a mobile application, so it runs on a smartphone, and we intend to do the same with our malaria screener. So this is how we envision our system in the field. This is our colleague in Bangladesh, and here is the smartphone. So what we want to do, and what we are doing, is connect a smartphone to a standard microscope here, light microscope, and have the camera of the phone look through the eyepiece of the microscope and take a picture of the slide here under the microscope, and then have our image analysis software count the cells automatically, so that our software can report back the counts or the infection ratio, and the human doesn't need to count. And if you do that fast and reliably, that would have a huge impact. And right now we have the first prototype out, and I will talk a bit more about what we are doing in processing-wise. So here's the processing pipeline that we have implemented using image processing and machine learning techniques. The first step is obviously to take digitized images of the slides, of the images, through the eyepiece of the microscope. The second processing step is cell segmentation. So we use image processing method to identify where the cells are, segment them out. Then we compute features. The features are descriptors, mathematical descriptors, like, for instance, color, right? We describe what a normal cell typically look like. It usually has a brownish color. And then the abnormal cell will have some pink-purple color in it, describing the stained parasites. So these are the features. We also use texture features that mathematically describe the horseshoe shape of a parasite, so that we have descriptors for the parasites. Then the last processing step is the actual classification and machine learning that discriminates between abnormal and normal or infected, uninfected cells using statistical methods based on the features computed. And then we output the infection ratio. The infection ratio here is the number of infected red blood cells divided by the number of red blood cells that we detected. Usually in the field they count up to 1,000 and then report that ratio. This is also called parasite count. Another ratio or another measure they output is parasitemia, where they relate or where they extrapolate that on 1 milliliter of blood. It's basically the same thing. The computation is a bit different. It all comes down to knowing how many cells are infected and how many cells are uninfected, and that's what we are doing. So right now we are reporting that back to the operator of the system. Mathematically, we use methods like level set methods. These are image segmentation technique, or also watershed to segment the cells. For feature computation, we use, as I mentioned, color features and texture features because they are able to discriminate between infected and uninfected cells. And for classification, we have experimented with two methods: support vector machines and deep learning. If you have lots of data, we can apply deep learning. At this stage, we had only limited data, so we used support vector machines. But we just finished, actually, 2 weeks ago, data collection in Bangladesh. We have now 200,000 cells collected, annotated, and so we will now proceed with deep learning. I will elaborate a bit more here on the next slides. As I said, we have collected data in Bangladesh. That's very important because we need to train our system, right? We need to compute these features. We need to tell the system how an infected cell looks like and how an uninfected cell looks like. So we have used an online annotation tool, Firefly, from the University of Missouri, which we are collaborating with, and have an expert slide reader drop points here on the uninfected cells, green dots actually, and red dots on the infected cells. You see, this is an infected cell because here's the parasite, here's a parasite, here's a parasite. Well, these are all parasites, and the rest is normal. So we use that data to train our systems. And by now, just 2 weeks ago, we have finished collecting 200,000 of these slides. We have 200 patients and 1,000 annotated cells for each patient that we are now going to use for training. So let me step back to the pipeline that we have here. These are, again, the 3 processing steps: cell segmentation.
So those all look like very high quality slides. The real world is messy granules of dye, badly done smears, confounding disorders like sickle cell, and this is a hemolytic anemia, so you get misshapen early cells that are nucleated.
Right.
Does your training set include noisy,
yes,
bad quality examples? Because that's the real.
It's whatever we are getting from the field.
But they may be only sending you, wanting you. They may think that you want the best slides, and they may be filtering out the ones you most need to be able to have a robust ability to detect noise.
It's a good point.
Yeah, but we didn't give them any advice to particular favor some slides because that will hurt us in the end. If we want to deploy a system, practical system that works, we cannot be biased towards anything. So we didn't give any specific direction of what to collect.
Well, not to pursue it, but I think you actually already have a bias because what they may say is, well, we don't want those people at the National Library of Medicine to think that we're bad technicians, so we're just going to throw out the bad slides and we'll just send them the good ones, right? So they know we're good research collaborators. So I think you might have the problem and not know it.
But is it true that if you train the machine on good slides, that it can apply that to poor slides?
No, because the problem is the poor slides look like malaria. Dye granules sitting on top of cells, nucleated blood cells look like parasites. So you really need that noise to have a robust classifier.
I mean, basically, the machine learning classifier categorizes things according to what it's seen before. So if normally you're going to see degraded images, that's what you want to have in the right proportions in your training set.
Okay, thank you.
So this slide visualizes the first processing step, the cell segmentation. And here are some of the problems maybe that you mentioned. Don't be confused by the colors. This is an color level set, technical term that we use. So all neighboring cells have different colors here. But you see that it's a challenging problem. For instance, let me look at some cells here. For instance, right? You have 2 cells and it's segmented as 1. The same here, 2 cells segmented as 1. So this is very challenging if you have the touching cells here. So we made some strides to solve the problem, and you see here our algorithm works nicely. It's touching cells, no problem. So this is something that we actively now research here to solve these touching cell problems, because that can very often happen, and that would affect our counting. But overall, we have, I think, a good segmentation here. And that has all been implemented on a PC under MATLAB, and we are now porting this on a smartphone. That's what we are doing. But let's go to the next processing step. So the next processing step is feature computation. So we describe typical color and texture features for these cells. And then the classification, the machine learning part. So this is the interface of our system that we have right now. So we can press a button here, and then the classifier that has been trained with the training data that we collected with the annotations from an expert then outputs the classification and puts the dots on each cell. So this is not a manual, but this is an automatically generated dots here. So green is normal and red is abnormal. So it's mostly correct. I think there may be 1 or 2 wrong ones here, but in general it's correct. It shows here red dots on the abnormal ones and green dots on normal ones.
No, there's actually quite a few pardon me, so I'm a hematologist. There are quite a few incorrections there, but with your collaborators, you'll get it right eventually.
So, and so here's there should be everything correct. So there's a close up on some section here in the slide.
Yeah, so that's a segmented polyneutrophil there. The one you have. So essentially, you're picking up, calling white cells as if they were red cells.
Well, we will have an algorithm that can sort them out. Right? So here is the training data, how it looks like, how we trained our algorithms. So on the left-hand side, you have normal cells, all look brownish. And on the right-hand side, you have infected red blood cells. That's how they look. And then we compute the features and discriminate between. This is a subset of our training set that we used to train the classifier. We did some evaluations here on slides, computing the infection ratio, the manual infection ratio, as it has been computed by experts by looking through a microscope, manual counting, and then our automatic infection ratio, and that is the result here. So we have an average error per slide of 1.18%. This is how it looks like. So the red line here is the ideal distribution where we want to be on the line, and if we are off, that is counted as a mistake. That's where our system we are right now, but we haven't yet started training with the 200,000 images. We have used deep learning though. We get about the same performance with the SVM, but now what we are doing now is training with 200,000 images, and we expect to have a better classification performance. A neural network is used. It gives you an abstract. You have several layers here that are connected. Try to mimic the human learning in the brain as close as possible, as far as that is possible with the state of the art. And it's a mixture of filters and convolutional and pooling layers, and your representation of this input gets more and more abstract, and in the end you have a decision if it's infected or not infected. So the input is one of our 200,000 cells. Here you see a cell chip, and at the end the neural network after training will say if it's infected or not infected. So that's what we are doing right now. We are training with our large data set this neural network and see if we get better. Right now we only have it trained with 16,000 cells. We have now 200,000, so we hope to get improvement there. Here this shows again the severity of the problem. There are about 170 million blood films scanned under the microscope every year. So, this is a large number, but if you really visualize that and present it here that way, that is really impressive. And even the people at NIID didn't know that. Just when I computed it, it looked really impressive. So if you just assume that a slide is 1 millimeter thick, so if you put them all on top of each other, you have a mountain that is about 20 times higher than the Mount Everest. And this has all been scanned manually in the world. So there's a large potential for doing that automatically and also more reliably and more cost effective. We have a large team of researchers here. First of all, here the core team from National Library of Medicine, Communications Engineering branch. We have collaborators at NIID that provide advice and also data, Rick Fairhurst and Abhishek Bansal. Then we have collaborators in the field, particularly Richard Mott, who is working at the Mydol Oxford Tropical Medicine Research Unit. So they will deploy our system in the field and also give advice and feedback for the user interface, for example. And also we have academic collaborators here at the University of Missouri and some summer interns that were very helpful in developing the early tools and gave help with annotating the images. Last year we got a innovation award from HSS Ventures. So this is now supported to deploy in the field for a smartphone, by the innovation award. The next step is to complete the malaria screener system on the smartphone app in particular, deployed in Bangladesh, have field trials, get feedback from the experts, adjust the user interface, improve the system. That will be on the agenda for most of this year. At the end of my talk, I will give you a short presentation of what we have now ported to the smartphone right now. Here are 3 screenshots, so just a slide here. And what we will give back to the operator of the system is essentially the disease severity here and the percentage, or is the infection ratio, what we called it before. So giving the percentage of infected cells. So here, that is what the screen of a phone looks like here, of an Android phone with our malaria screener. That's where we baptize the system. And so it will sit on a phone, run on a phone that is attached via an adapter to a light microscope. And I can make a video here. Show that. So the first step is to start the Malaria Screener app and start a new session for a patient. The user interface will still change because this is by our design, but we will get feedback from the people in the field. Then we can enter a patient ID or whatever identifies uniquely the images we take and the counts we process, a slide ID. And then we can capture an image via the iPhone camera here. So pressing that button here, you make it round in a later iteration. There's still something to do, but the essential principle will stay the same. So here's the captured image displayed. And then we automatically start our software and then report back the infection or disease severity and display what cells we think are infected and allow zooming in, zooming out, and so forth. So that is the status of our project right now, what we have implemented on the smartphone. We are now, right now we have a simpler version of our segmentation ported to the smartphone. So we will replace it with a more sophisticated segmentation module. But the classification should be in place. After retraining our deep learning network, we should be able to replace it very easily. And feature computation is in place. And I think the features we have are very powerful. We can, of course, there's a whole set of other features we can use, but I think they are very powerful. So that's the status of our project right now. We have a few publications here. One that we just submitted here is an extended version of the healthcare conference that was just the other month at NIID, where we presented our system, and we got quite some interest from companies like Bosch or what was the other one? HP, right? HP. And we also have a related project for malaria diagnosis, but not on blood, but non-invasively in the retina of the eye. Actually, we discovered, together with NIID, that there are white particles in the eye, probably parasites. They don't know yet. They are trying to figure it out. And if we could see them early on, that could be a very early indicator of malaria. So that's a very hot topic right now, I think. But there's a large research component to it. We need to find out which particle it is. But in principle, we could use image analysis to detect malaria in the eye. And then we would have a non-invasive, very easy method to detect malaria very early on for kids to save their lives. It's a related project. And with that, I conclude my talk, and thanks for your attention.
Can you discriminate amongst the different types of malaria?
Not yet. We could. If we have training data, we would separate between falciparum and vivax. We have actually data for both, so it's just a matter of working on it and doing it. Yeah.
So since we are working mostly in Bangladesh, that's where the software is actually implemented. That's falciparum, almost,
Mostly.
almost completed. But our collaborators at NIID have a whole bunch of data from Cambodia, which is silence. But we are taking this one step at a time.
So does the app show the image as it's scored and let the person say, it's good, I like the results? Because it seems it has two aspects. You could use the best that human beings are at saying, well, you know, it's a terrible image. Why did you even try?
Yeah.
Right? And you'd have the risk that if it just gave a number, they'd trust the number. But it also seems you could close the loop for your machine learning. And if you ask them to nominate, that's a bad call, that's a bad call, that's a bad, then, and send that back to you, actually your algorithm, by the Lindbergh rule of systems that get used get better, this system would get terrific because you'd be using the intelligence of the experts to continue to refine.
Exactly, yeah. Or we may even automate the process of rejecting slides. We could say this slide may not be optimal and just ask to not take another picture. That would be also possible.
Again, there's a protocol for going down the slide because what you showed was one field of the many. You look at 100x magnification. And you count 1,000 cells, so they often move through several fields on the slide before they complete the 1,000 cells.
Yeah.
And they will skip a few, but there's an order before. So what we showed in the video was just an early implementation of what you mentioned, the rejection of entire fields, rejection of cells that were miscategorized by the other software. All that is in our workflow.
Great. I don't know.
So now your rate limiting step will be the affordability of a compound microscope. And so I'm wondering if anybody's looking at some of these lower cost platforms like Foldscope to...
Yeah, exactly, Foldscope. We have definitely looked into that. This is a very active field. I mean, there are many adapters for smartphones there. There are small portable microscopes. But I think the field is not mature yet. And especially the Foldscope that you're mentioning, I don't think the optics is good enough for doing that right now. But if you Google, you will see one or two startup companies that are trying to jump on this bandwagon. And also there, I mean, ideally what you would like to have, is a device where you just insert the slide directly, right? As a small portable device, put the slide there. And people are working on it. There's actually a small device from the Fletcher Lab in Berkeley and also with people from Dr. Nutman here from NIAID for another virus, Loa virus, and that works to some extent. It's still prototype, but it's also an easier problem because the parasite is larger and it wiggles, has motion. So it makes it easier. But this is a very active field, and I expect that in 2 years or so from now, we probably are way closer. So, yeah.
Or no slide, right? So you have a laboratory on a chip, and you just put your finger, and it does some kind of biochemical assay. It doesn't route through an image. So
we were trying to play it safe by using a standard microscope and an adapter because we know that gives us the image quality we need. But in a few years, I mean, we are independent of hardware. We are developing the software here. So if the hardware gets better, we just use our software or retrain maybe, and then we can are still in the business, so to speak.
This is terrific, and I have two questions. The first one actually follows the line of Dr. Mazy's point. Different cell phones have different cameras, lenses, and algorithms to produce the images, and I was wondering whether that creates challenges for the training, in that you have to adapt the training to the different models of cell phones.
I mean, image quality is decisive here, and so we are using the best camera in the field from a Samsung S6 camera. That's what we do, and to me, the images look very good. I mean, I definitely good enough to do our image analysis.
If someone in the field were using an iPhone, would the data still, but you train on a Samsung, would the results still be reliable?
So you're talking about true top-of-the-line lenses and optics, so you would not have problems there. My greater worry tends to be when you're using maybe a 2 or 3 year old phone, where the optics were weaker than they are today. Then the picture would be grainier, perhaps, or you would not get the separation in the pixel, the dynamic range of the colors. You could have a problem. But so we may have to eventually get to a point where say, well, this is minimum this hardware standard on which it's trained. But that's, I think, still a few steps away.
And the selection of the phone was really not our choice. It's our collaborators in Thailand and Bangladesh. Dr. Richard Mon, who was listed on that slide, he's the one who finally made the decision and told us what model.
I just don't know if it came across, but there's 2 ways to use this. One is to diagnose, and you find a cell with it. The other one is do counting, and I didn't know until we got in this project that the largest volume is daily follow-up for the patients, so you're counting. So that's less, you can be off by a couple %, without making big harm, because they're trying to see progress and make decisions about things. And I think it was like 10 to 1 or 20 to 1, some very high ratio of the daily follow-up versus the initial diagnosis.
Yeah, and if you actually, so people, if they serve as their own control, and you probably don't do it this way, you probably look at your image sets independently, but it's known, for example, if you have sickle cell disease, you have a constant rate of hemolysis, which is different than the next patient and the next patient, but yours tends to stay the same. And so that produces, say, nucleated red cells, and the small nucleations can look like parasites, it's a problem. But in a sense, your own images will become highly robust with respect to their comparability across time with your own set. So it's at least one of the ways to improve your quality is to be able to not view them as though all images were independent.
What's amazing is that you're doing the first runs of the classification on the phone, on the Sentinel 6. We actually train hundreds of cells right there in a matter of seconds. The hardware on the phone has gotten so much better that what was a year ago was that it would take a few seconds to a few minutes to do this. It just does like that. So looking forward, it's using the phone like a computer is not out of scope.
Sure. Good stuff.
Dr. Taylor or Colonel Nunn?
I actually have another, I was talking to them before about, I have another application that's probably not quite as not quite as urgent a health need, but in a public health lab to check the quality of a water tower, you have to look at slides that have many different colony types on them and pick out the Legionella as colonies, which are quite tiny and hard to differentiate. And I'm thinking for that sort of application, you could use the same sort of software to identify particular colony types. So I think it's fantastic.
And also tuberculosis.
Yeah, the other project we are working on for lungs, yeah. Okay.
So my initial instincts are this is a tremendous innovation. The group's to be congratulated on fantastic effort and truly international collaboration, an effort that I think will have tremendous impact going forward. I got to tell you, as a trained internist and allergist immunologist, the immunology piece, the clinical laboratory immunology piece is nice, but this particular piece of work is well outside my expertise. So it gave me the opportunity to look into the literature a little bit, and I won't say become smart, but maybe a little less stupid in the field. But it is very exciting to see these potential applications. I want to get back to the scope of the problem. You mentioned, what is it, 400,000 or so in the last year in Africa alone. I think one of the more commonly quoted numbers is 600,000 cases
This is the number I had
a year
before,
worldwide,
actually,
right? And 2 million deaths to go along with them, which is tremendous impact nationally. And I didn't want to overlap with Dr. Taylor's comments, so I'm going to narrow down the scope a little bit and tell you that even in uniform, we have stringent measures for travel to endemic areas to the point of requiring use of anti-malarial prophylaxis. You would think we would never get infected, right? Well, that's not the case. I can tell you that there have been 800 cases diagnosed in DoD service members since 2005, not an insignificant number. Even since then, the numbers have started to go down, particularly as we deploy less to endemic regions, but it's still a significant problem. There was just a recent report in January of this year that talked about our experience with malaria in 2005. There were 30 cases among U.S. service members who should never get infected with the way that we have prophylaxis. We think that they didn't adhere to their regimens or didn't adhere to the directly observed therapy that we often employ. And it's probably physicians, the worst patients in the world, who contributed to that number. But I'll tell you that it's as recent as the Ebola response. There were 5 individuals who were part of that Ebola response who came back diagnosed with malaria. So this is a significant problem. I will tell you that our mantra in military medicine is to get diagnostics and medicines close to the patient at the point of injury or illness occurrence. So in looking back at those 30 cases, they went to identify where was the diagnosis being made. So you would think these are all endemic areas, are probably being made in combat support hospitals or military treatment facilities downrange. Well, in fact, the vast majority in the top 3 facilities that did the diagnosis was in fact either a major hospital in Europe or here in the US. So it tells you that these patients are getting evac'd with undiagnosed disease. This is technology that offers that potential to get that diagnosis earlier in the course of disease and implement therapy a lot earlier. We are very vested in getting our service members back to duty. I'm not going to say somebody infected with malaria, we're going to treat them and keep them in theater and actually send them back. It might be for an early case, but getting that diagnosis early, I think, is a tremendous opportunity. And it's technology like this that I think we can employ. In fact, I think that the Department of Defense, the Gates Foundation, and the NIH participated in some similar technology with regards to malaria diagnosis. We're well vested in research and vaccines, but we're also interested in new technologies such as this one. So it is very, very tremendous. I was very interested to see the video to see exactly how yours was set up, because they are deploying the cell phone technology in medicine in several disease areas, it appears, and it is emerging technology. And the less sophistication and the more applicability to the different models of phones, as the discussion was talked about, is certainly the right business model to pursue. Because if you start looking at specific attachments, you're going to be chasing whatever the power or data port is going to be with each model of phone, and it's going to add to the cost of the machinery. So simple lensless setups, such as using existing cameras in the phone that either go through a microscope lens or a small attachment that you can put on top that has a lens in it, and you slide the slide underneath it, capture the image and send it. It's a beautiful thing. So that offers the opportunity, I think, for the Department of Defense and others to utilize this technology closer to the field. And some of the discussion we had before we got started is it is also important for research. So as we chase the holy grail of a malaria vaccine, field trials that depend on accurate diagnosis of malaria for participants for field infection, having validated technology, and I think that's one of your next steps, is to do that field validation to make sure that the results you're getting are true and meaningful. This could help tremendously some of the far forward vaccine trials that are underway for this and many disease states. So again, I applaud you for your efforts, and thank you for allowing me to discuss this in a little bit of detail today.
Thank you.
Can I have one more question?
Sure.
So, I think I heard that you're looking at about 1,000 cells to get an accurate number.
Yeah,
Okay.
that's what they usually do in the field.
What about drug resistance? How many have you got to look at to know that you really clear the patient?
Oh, then it's a much higher number. If you want to
Yes,
say that
so
somebody is
if
cleared,
you-
it's
you
a
look-
way higher number. Yeah.
Yeah.
Any other questions or comments?
I mean, it would be interesting if you look at the bigger picture. I mean, this is malaria and the costs and the disease burden is so high. But once you get more sophisticated in this technology, you could look at endemic areas.
Yeah.
You know, look at Martha's Vineyard or somewhere they have babesiosis or some of these other internally localized diseases where you would just get a better technique of making that diagnosis and then exporting it when these people travel where they wouldn't have that expertise, where they now have a method to look at it better. And again, I think in the bigger picture, if you look at locations that don't have the expertise, now you're bringing more sophisticated technology that may be, you know, manageable financially to locations that don't have that expertise, so that smaller places would now have the ability to have access to make a more rapid diagnosis and therefore more rapid intervention. So it's just that it just opens up an incredible amount of technology and treatment modalities that we may have in the future.
Okay, I'm going to ask a really ignorant question. So you mentioned babesiosis. So something like Lyme, you could see.
Well, babesiosis has actual intracellular kind of Maltese cross picture, which again that you could train to. So if you look at those areas, you know, Martha's Vineyard and
Yes.
and Nantucket, where that disease is endemic, or along the northeast coast, then you could look at that particular ones. I think ehrlichiosis is another one. But there's some of these intracellular parasites that, if you have the sophisticated technology where you can
could see it.
recognize it as that entity in those endemic areas, it might help you in that management. So it's just a fascinating technology.
Malaria brings up a lot of interesting problems. I was a physician in the military in Vietnam. And one day I went down to the air vac center, and there was a plane with 125 soldiers on it. And they had gotten on there because each one of them had a temperature above 104, and which of course meant malaria. And I had 2 hours to decide which ones I had to keep there and do dialysis on. It was all falciparum, or send them up to Japan, which would take a day to get there. And that was the big problem.
Well, thank you very much. It's a lot of interesting implications, so thank you.